All right. Good morning, everyone. I understand it's a frigid Friday, December 13th in Toronto. I want to welcome everybody to our annual Walter Wright review. So this year's Walter Wright meeting was to celebrate the 75th anniversary of what I consider a historic landmark in our specialty, which was the first implantation of an IOL by Dr. Harold Ridley. And we covered cataract surgery last weekend at the Walter Wright meeting with some of the esteemed giants in our field. We had wonderful guest speakers including Dr. Tanya Trin, Dr. Uday Devgan, Dr. Kathy McCabe, Dr. Mitchell Weichert, Brendan Ayers, and Bobby Osher. I do want to acknowledge the hard work that our planning committee did for probably a year and a half, led by Dr. Alan Slomovic. It was co-chaired by myself and Dr. Rosa Bragamelli, and our committee included Dr. Kay Lamb, Dr. Lawrence Weisbrod, Dr. Mariana Colazos, Dr. Carla Lutchman, Dr. Ryan Mason, our PGY5 resident you see here, and of course our committee could not do what it did without Sandra Gauci. And I do want to give a special shout out also to Dr. Austin Pereira, who helped manage our social media that weekend, which is becoming increasingly important. So there was a lot of great talks, and we've asked our PGY5 residents to perhaps summarize the meeting in about an hour for you. So I'll hand it over to them. And PGY5s, thank you for putting this together for us.
Great, you're very welcome. So the first summary of the first two sessions was done by Jovi Wong. She couldn't be here today, so she recorded a presentation for us that I'll play now.
Hey there, this is Jovi, PGY5. I'm going to be reviewing sections 1 and 2 from the Walter Wright 2024 conference we had last week. So our conference on Friday kicked off with a talk about the evolution of cataract surgery delivered by Dr. Rosa Bragamelli, and she provided an overview of how cataract surgery has evolved throughout history, starting with couching in ancient Egypt to the newest, most exciting advances in robotics for cataract surgery, most of which are still to be seen. Some of the interesting things pointing out were the development of the capsulorhexis, and this really made possible the progression of phaco and also the current use of more premium IOLs, and also talking a bit more about the benefits of using a more physiological intraocular pressure to get us a better and faster visual recovery post-surgery. We then had a wonderful talk by Dr. Tanya Trin, who's a former cornea fellow here in Toronto, and she gave a really fun talk named What the Fuchs, full of Australiana memes, like here, this toilet filled with presumably some Australian toads. And she talked about considerations for Fuchs patients in cataract surgery. So in particular, we have to actively look for it. It seems simple, but often easy to overlook if we're looking at other things. And that we should, make considerations early relating to Fuchs patients, and consider referring them if we might be thinking that a staged or combined surgery with corneal transplant might be needed. And some of the consequences for not thinking about this would be, unfortunately, patients would not be expecting that they might have delayed healing from their cataract surgery with you, or possibly that this could lead on to a cornea transplant later on, and it's always hard to manage expectations after the fact. And so this was a great talk where we talked about these things. We then had Dr. Clara Chan, one of our cornea attendings, give us a primer on corneal topography. And she gave us a really nice, efficient summary of how to review cornea topography for cataract surgery planning, with some tips on interpreting scans and planning for toric IOLs. So here's the summary slide from her presentation. With every topography scan, we should always assess the scan first and see if it looks reliable and there's no obvious artifacts. Then we should see, is there an obvious pattern that would relate to astigmatism? Is the astigmatism regular or irregular? Always correlate this clinically with your slit lamp exam, and ensure that you're looking at the biometry data as well, and does it all match up together? And importantly, using topography can help us rule out corneal irregularities that could mess up our IOL calculations. It could also help us diagnose keratoconus or other corneal pathology, and it's important to know these things before we decide on a toric or before we decide on cataract surgery. And can also help us identify if the patient has had prior refractive surgery, because sometimes patients forget to tell us this in the history taking, and but we will know from topography whether that has happened in the past, and of course to help us identify the axis for toric IOL placement. And then we had the first ever Sharif Elderfrawi named lecture, which was delivered by Dr. Bobby Osher, one of our special guests, who has contributed so much to cataract surgery videos and teaching. And so very fittingly, he showcased 4 of his very own grand prize winning videos, most of which were really fun to watch. And some highlights I thought included him showing a video where he displayed experiments that he conducted to show that phaco for mature cataracts is safe. And to do that, he had a model eye in which he was phacoing sharp rocks. And then I thought it was also cool to see his video where he tested 7 theories for the mechanism of dropped cataract nuclei. For my side, I always thought it was probably gravity related or a pressure differential related or something like that. So it's really interesting to see how there is a significant role of surge, and how that has changed how we look at how we approach surgery to make it safer. And this then brought us to the first debate that we had for the conference, which was LPIs versus phaco for the management of angle closure. And of course, we had Dr. Matt Schlenker, who argued against LPIs, and Dr. Davian arguing for LPIs. It was a very entertaining debate. At some point, there's some artificial intelligence used, and a good discussion on the management of angle closure suspects and angle closure glaucoma. So here I've included some of the summary slides from the main points in the debate. And here on the left, Dr. Schlenker argued that there are many risks of LPI, including positive dysphotopsias, IOP spikes, AS formation, development of floppy iris, and other issues. And meanwhile, Dr. Yan argued that LPIs could still be indicated in certain cases, and that there's also this consideration of patients who might find it challenging to follow up frequently, and mixed mechanism, longstanding primary open angle glaucoma, for which the studies regarding LPI versus phaco may not apply. So it was overall a very interesting debate, and learned a lot about management of angle closure. We then had, as our last talk for section 1, discussion about the use of OCT macula prior to cataract surgery, delivered by Dr. Panos Christakis. And of course, this talk really highlighted many good and important reasons for why macular OCT is a good idea for many of our patients. And here I've included some of his summary slides. On the left, we can see, the advantages of pre-op MAC OCT include, it's non-invasive and quick, can detect subtle pathology, which might require treatment before cataract surgery. Could also help us guide our lens selection and refractive target. And it could also change our plans for pre-op and post-op care in terms of drops. Yes, there is a cost associated, but here on the right, he also includes the particular patients in which it is particularly important to do a MAC OCT. Here, for example, this includes where we see macular pathology on the clinical exam, such as ERMs, loss of foveal reflex, drusen or RP changes, diabetic retinopathy, or RVOs. Doing a pre-op macro CT might help with diagnosing some of these problems, but also in determining whether certain lenses are suitable or not. It's also important to make the OCT part of the workup. If a patient has vision worse than you would expect, given the degree of cataract they have, or if their symptoms don't seem consistent with cataract alone, like there is a scotoma, metamorphopsia, or other issues. So this, we're sort of working up whether there might be a retinal issue instead of just a cataract. The other important point he made was that often we have patients who are waiting for cataract surgery, and while on the wait list, they may, if a patient develops rapid worsening of symptoms, something that is not consistent with their cataract getting worse, it's important to do an OCT to rule out a problem. This brings us to section 2, and our first talk was delivered by Dr. Tanya Trin. And so she came back to give us a discussion of cataract curveballs, which were cases where there might be special considerations for each eye of the patient. So there might be some thoughts about tailored refractive solutions for each eye, leading to the best outcomes for the patient. So, for example, here we had this complex case on the left side, where one eye had a previous issue of, having had a vitrectomy for a posterior capsular tear. There's zonular weakness. There's also high myope. So how to manage cataract in this situation, because we want to reduce the risk of a future retinal detachment. Meanwhile, the other eye, the patient has a huge anisotropia. They meanwhile have accommodative status, which is preserved in that eye. So how should we help them refractively to manage this? And in another patient, their one eye was suitable for regular phaco, but the other, Dr. Trin talked about using a pinhole lens, in which there's a pinhole integrated into the lens to help with accommodation afterwards. So that was quite interesting, just to consider that each patient is unique in their visual needs, and that even each eye could be unique in its visual needs. We then had another of our guest speakers, Dr. Brandon Ayers, give a talk about the complex cataract, in which he reviewed a lot of different tools that we can use in our phaco surgeries to help with complex cataracts, including the trypan blue. A lot of the time we just kind of put it into the chamber and hope it sticks, but about rolling it on, which might be more efficient and safer. Also dealing with a fibrotic anterior capsule, so sometimes this just needs to be cut. You can't just rip it off. And working with iris hooks or Malyukin rings and capsular hooks, just to handle a variety of different cases in which you can more safely extract the cataract for the patient. And finally, the section 2 concluded with the Walter Wright lecture, which was delivered by another of our guest speakers, Dr. Uday Devgan, who's better known as Cataract Coach. He gave an exciting video-based lecture with commentary from the expert panel he had there with him. And so we were treated to, a very long Cataract Coach session, where he showed us several of his own surgical videos, reviewing common complications like PCR, anterior vitrectomy, changing your IOL through the surgery, zonular dehiscence, and other issues. And it was a very interactive lecture where he would, show, the next decision-making step and have the panel comment on, what they would do next. And it was interesting to see when there was differences between what he would suggest or what the experience of the other surgeons had been. So it was great to see all of that, and lots of videos. Here are a few slides where we see the Cataract Coach style videos, where we have, here on the upper left, where after the surgery there was somewhat of a traumatic mydriasis, and So they were discussing whether an anterior pupilloplasty should be done. Then in another case, what to do with a floppy iris or iris prolapse. Then on the right-hand side upper, we saw a case where the CTR was released, and then we saw a lot of wrinkles in the capsular bag, and then we talked a bit about what should be done next and next steps. So it was very practical and really nice talk where we reviewed a lot of cases and common complications, some of which we've seen ourselves or have seen others show at video meetings, and so it was really cool to see how these were all managed. And with that, that concludes sections 1 and 2, and I'll let my colleagues continue with the rest of the meeting. Thank you.
Hi, everyone. I'm Austin Pereira. I'm one of the other fifth-year residents. I'll be talking about Section 3 of Walter Wright, and a big shout out and congratulations to the entire organizing committee. Also, one of my co-residents, Ryan, for helping organize. You guys did amazing. So this is a Section 3 that focused on biometry. So there are a number of different talks here. I apologize for the speed. I just want to make sure I get the main points for all these talks across. It was a bit of a dense section, but a lot of great takeaway points. The first talk was given by Dr. Weichert from Baylor, and he was talking about eye wall calculations in atypical eyes. So the current European report in 2022 and 2023 said that 74% of cases of cataracts were within 0.5 diopters of refractive error. Now, 0.5 diopters of refractive error is kind of that surrogate marker of success that a lot of surgeons and especially studies use in terms of refractive success in cataract surgery. But where do we fall short with regards to our success? When do those cases fall outside of that 0.5 diopters of refractive error? Usually in cases with longer or shorter axial lengths, when we don't have a proper effective lens position, which is a very key factor in the last 5 years for predicting the refractive success of cataracts. Post-op refraction measurements, so if we're not taking good pre-op or post-op refractions, that's how we're really having poor refractive errors in regards to our measurements. Garbage in, garbage out was a big takeaway. And the corneal power measurements will kind of go into that. Short and long axial lengths really are the main drivers of poor refractive success in cataract surgery. How do we mitigate refractive error? Well, we want to add more measurement variables to the regression models. These regression models, the more information you put into them, ideally, the better the prediction of those IOL power calculations. Possibly ray tracing formulas or using big data with artificial intelligence. Maybe AI can help us with predicting the refractive targets and the refractive outcomes for cataracts. Unfortunately, one of the big take-homes from Dr. Weichert's talk was more modern formulas are actually black boxes. So we actually can study how they perform, but we don't have the access to their inner workings. We all know the formula for the SRKT formula, for example, but we don't know how these newer Barrett or Kane formulas actually work. Longer axial length eyes are over 25 millimeters, and it's relatively common in the population. They tend to underestimate IOL power, leading to those hyperopic surprises. There's about 50 to 83% accuracy in these cases, probably closer to the 50%. And one of the driving factors is that for these eyes, we're assuming a single index of refraction for the entire eye. But as we know, the longer the eye, the change in proportion of the length, which skews the measurements. For shorter axial length eyes, those are cases less than 22 millimeters. Not as common as longer axial lengths due to the myopia epidemic have going on, but it tends to overestimate the IOL power. And this is due to the axial length and effective lens position kind of playing tricks on our measurements. Now, keratoconic eyes, they're much less common, but they do cause a lot of troubles with their IOL power calculations. Usually because they're ectatic, it leads to issues with measurements of the keratometry. And there's about 24 to 72%, really close to the 24% that fall within that 0.5 diopters of refractive error. And everyone's least favorite post-laser vision correction eyes. What formulas do we use? We'll talk about that later, but the myopic ablations lead to hyperopic error, and the hyperopic ablations lead to myopic error. And again, poor corneal readings and the anterior and posterior corneal curvature relationship is affected in these cases. I personally screenshotted this slide when he presented it. It's the best formulas for every certain condition. So for longer eyes, consider the Kane and Barrett formulas. For shorter eyes, the Zeiss AI and Cook K6 formula is relatively newer. Keratoconic eyes, there's actually a Barrett and Kane keratoconus IOL power calculator. So you can find that online. And then the Barrett True K is a very good high-powered formula for post-laser vision correction eyes. Next, we have an amazing talk by Dr. Amandeep Rai where we talked about how do we get these calculators to get 20/20 vision. This is a landmark study and a landmark figure from the 2018 study by Mellis et al., which compared a number of different formulas in 18,000 eyes and looking at the refractive error. And you can see here to the far left that the Barrett formula had the highest proportion of cases within 0.5 diopters of refractive error. If you can see my cursor, that is the deep green bar, and it goes down to Olsen, Haggis, and the holiday formulas that we all know. There was an update in 2019 which included the newest Kane formula, and Dr. Rai likes to remind us that Kane was a resident in Australia when he made this formula, so to push us to improve our refractive predictions and our calculations. And the newer Kane formula with the updated Olsen formula actually performed better than the Barrett formula in this 18,000 eye population. And we really see that reflected in the highest proportion of eyes within 0.5 diopters of refractive error. As we can see here, this is the Kane formula, the Hill RBF, and Olsen. So this newer Kane formula is probably a good option. This was an updated study in the UK population in this graph. So the biggest takeaways from Dr. Rai's talk was that the Barrett Universal 2 is a great formula and should be the workhorse as it is already preloaded in our biometers. However, newer formulas such as Kane may be more accurate, but really adopting this is tough because it's only available online. But it may be a good idea to put in your measurements into the online formula, especially in atypical eyes, especially longer eyes for the Kane formula. And the posterior cornea can be predicted or measured, unclear which is better at this point in time. Now we had an amazing talk by Dr. Rootman, which looked at IOL calculations in post-laser vision correction eyes. There's a lot of challenges in these eyes. Really, measuring the accurate corneal refractive power is incredibly important. And the main reason why is that anterior and the posterior curvature relationship, which sometimes is assumed, has been altered. Also, predicting the effective lens position uses keratometry in its prediction, but now we affected the keratometry, so the ELP can be affected as well. And there's a number of different formulas here. Really, the Barrett True K shows the highest probability of getting within 0.5 diopters of refractive error, but there are a number of different formulas. There's the Evo, Haggis, and Shamus. Also, the Barrett True K in this study in 2024 showed the lowest mean absolute error as well. So the Barrett True K shows to be a good promise and a good workhorse for these post-laser vision correction eyes. So the Barrett True K is quite accessible. Everyone knows how to access it in the ASCRS and the APOS online websites. All the regression models, especially for normal axial lengths, work quite well. And really to counsel these patients, really important to set expectations for these post-laser vision correction eyes, that getting that accurate post-operative refraction may be tough. Sometimes you need an IOL exchange. Next, we had a talk by the cataract coach himself, Dr. Devgan, on the future of IOL calculations, really building on what we currently have. So we summarized really the first and second generation formulas, which is the SRK1 and SRK2 formulas, going to the third generation, which uses a bit more of the biometric measurements in its regression model, like SRKT, Holiday 1, and Hoffer Q. And now we're kind of in that fourth generation of regression models like Haggis, Olsen, and Barrett, which better predicted the effective lens position by using white to white, lens thickness, etc. But he really focused that these are all static regression models. So anytime there's a new factor, we got to devise a new formula. But what about artificial intelligence? There's the Hill RBF, which is evolving, but there's no real backbone. What if we had a combination of formulas? So we used AI and ray tracing like Olsen does, with a bit of vergence. That is the newer lattice super formula. So the lattice formula, if you want to kind of peruse some of how its inner workings, can be found on iolcalc.com. Really easy to use website, a good user interface. And it uses a three-dimensional supersurface, which combines modern IOL formulas to generate the super formula to maximize accuracy. So if you have a short eye but with a steep K, it uses this model to predict which will be the best IOL power for your patient, and same with the other degree of spectrums. So it uses big data. They do crowdsourcing, so they take in information from people so they can improve their model. More than 3,000 users and contributors are using this, and it's growing. So really look out for that super formula in the near future to possibly bring us above that 80% accuracy for our IOL power calculations. So we can refine IOL calculation with the super formula and ability to improve and evolve. So there's a next talk with looking at the biometry, the current biometers we have. This is a bit of a denser lecture, but I just want to take away the main take homes. The keratometry can be measured by reflectance, Scheimpflug imaging, or swept source OCT, and axial length can be measured by swept source OCT or time domain. And the bottom right has the two biometers that uses both, swept source OCT with the Anterion and the iStar 900. And as we know, biometry and keratometry are the cornerstones of refractive cataract surgery, with swept source OCT giving us fast measurements, and it actually penetrates 99% of cataracts, which is pretty impressive. We all know there's cataracts that need to get an A scan because our biometry is not getting through. So the Anterion and iStar have three functions in one device: biometry, keratometry, and even anterior segment imaging. And these measurements agree with established biometers, which are a wave of the future. And finally, we have a really interesting debate between Dr. Arshinoff, who was pro-femto, and Dr. Basir Khan, who was against flax, related to femto or not to femto. That was the question in this debate. So Dr. Arshinoff began in favor of femto. Flax is femto laser-assisted cataract surgery. There is a perfect capsulorhexis, and as a lot of our cataract surgeons know, capsulorhexis is the life ring of IOL surgery. So a perfect rhexis, you'll have a great refractive result, ideally. Dr. Arshinoff has not had any anterior capsule tear-outs in the last 1,000 cases, and really in the top right there is the dimple down maneuver to help minimize the anterior capsule tear-outs. In a study in 2019 at Uptown Eye Institute found that with their femto cases, there was improved IOL centration, decreased aberrations, and precise refractive results. In the future of femto, this kind of got some oohs and ahs in the crowd that Dr. Arshinoff suggests that we can possibly do femto in both eyes, the laser in both eyes, and then do phaco in both eyes, which, as we know, could be risky if you have a complication in the first eye. The rebuttal from Dr. Khan demonstrated a number of studies showing that there was no significant difference in visual outcomes or refractive error between the two cohorts, and there's a significantly increased risk of anterior capsule tears and posterior capsule tears in the femto laser-assisted cataract surgery groups. What about centration? Everyone thinks that femto would ideally get better centered IOLs. Well, these studies in 2021 showed that there's no significant difference in IOL centration and no difference in tilt between manual or femto cataract surgery. There are higher incidence of anterior capsule tears and no difference in endothelial cell loss. Other factors against femto is we all seen these patients after femto with these subconj hemorrhages or suction loss. Not many surgeons use the wounds for the wound creation, so the architecture is not the best. And for small pupils, it's very tough to do femto. In addition, Dr. Khan brought up a very interesting ethical dilemma where if you were to have immediately sequential bilateral cataract surgery and you have a complication in the first eye, you should not go on to the second eye or at least fix the complication in the first eye. So really doing femto, it would be a very risky ethical maneuver because what if you had a complication in that first eye? And it was really eye-opening that Dr. Khan was really pivotal in bringing femto to Canada, and he performed over 2,000 femto cases and authored a chapter on femtos, but he no longer uses femto in his clinical practice, and we haven't even had time to go into the cost associated with the patient to femto laser-assisted cataract surgery. So some pros and cons to mull over. Thank you.
Hi, everyone. So I'll be presenting section 4 of the Walter Wright conference. So here I've listed the topics that we had, and all of them were around challenges that you can face during cataract surgery. So the first talk by Dr. McCabe was on managing complex cataract surgery, particularly with the zonulopathy. So she first focused on doing a good pre-op assessment, starting with history, asking the patient about any previous intraocular surgery, any previous history of trauma or intravitreal injections, which all these things can compromise the capsule as well as the zonules. In terms of the exam, she mentioned to focus on things like looking for transillumination defects, signs of pseudoexfoliation, looking for signs of angle recession that can indicate they've had a previous trauma that could have compromised the zonules, as well as looking for phacodenesis, decentration, or vitreous where it's not supposed to be. So the top left shows a photo of an A scan of a patient where you can see that there is a bit of a closer touch between the capsule and the iris on one side than the other. So that can indicate that there is some zonular compromise. In terms of managing these cases, she mentioned developing an actual toolbox in OR that you can pull out in situations where you think you'll need extra devices to manage zonules. So things that she mentions it's important to check you have in your box are trocars, having an AC maintainer, OVD to maintain your AC and keep the vitreous back if needed, having iris hooks, CTR, CTS, max grip forceps, micro instruments, as well as Canalog, as well as Myocol and Myostat. And things to keep in mind as well, if you need to alter the position of your lens based on how much support you have, is having bag sulcus conversion on hand, as well as a manual toric correction for LRIs if the patient was supposed to get toric lens. Some of the IOL options she talked about in patients with zonulopathy is placing a CTR in the bag and then placing a sulcus IOL and then pushing the optic back for optic capture, and that can help tampen that vitreous back as well if there's poor zonules. She also talked about the option of scleral fixated IOLs, as well as a review of 87 studies with scleral fixated IOLs. She showed that the study had similar visual and refractive outcomes and a similar rate of complications, except for more inflammation with scleral fixated IOLs, but then more pupil distortion with retropupillary iris claw IOLs. So there are a couple options you can have for these cases. Intraoperatively, she mentions if you think there's going to be a lot of issues, you can place trocars in advance while the eye is firm. If you're having trouble creating the capsulotomy, because it can be quite flimsy if you don't have zonules for the countertraction, is to place sequential hooks as you're doing the capsulotomy to create countertraction while you're going through. And as well, as you can see in the photo, is to place the CTS as early as possible while you have good corneal view. Other techniques to use are to use hydrodelineation, minimizing sculpting and rotation of the lens to prevent trauma to the zonules, using low flow phaco, frequent OVD to maintain the AC, as well as having triamcinolone and intracameral antibiotics. The next section with Dr. Ayers was on putting it all together with anterior segment reconstruction. So he showed a very interesting talk where basically his concept was that you should master all basic set of small steps, and anterior segment recon is all about combining these steps into one. So the first thing that he mentioned that is pretty important for all starting residents is the anterior vitrectomy setting. So the top one is showing you cut IA mode, and the bottom one is showing IA cut. So for cut IA mode here, you can see the first step that you press down is the infusion. Then when you go down, that turns on your cutter. And the final step in the pedal is aspiration. So this is particularly useful setting. In the photo, you can see when you're actually doing the anterior vitrectomy, they've placed in triamcinolone, and right now they're cutting vitreous. So use cut IA mode when you're doing anterior vitrectomy to remove the vitreous. For IA cut mode that you switch on the Centurion, the cut and aspiration are reversed. So the first in the pedal is infusion, then it's aspiration, not cutting, and then the last part of the pedal is to turn your cut on. This is helpful, as you can see in the photo, when you want to actually use your vitrector to strip the cortex. So you go under the cortex, you engage infusion aspiration, but you do not press on the cutter because you don't want to rip your anterior rhexis. You pull forward, and you can either just turn off your cutter to just use aspiration to remove your cortex, or keep the cutter on and cut your cortex with that. So he mentioned the importance of knowing the difference between cut IA and IA cut. Then he showed some interesting cases. So the first one was on IOL exchange in a patient with previous multifocal IOL that was unhappy given the very large rhexis they had. There was decentration of the multifocal IOL, and so they wanted an exchange. So he removed the multifocal IOL. And because he couldn't use the anterior rhexis for stability, he actually made a posterior capsulotomy, then did an anterior vitrectomy through this posterior capsulotomy opening. And then he placed a 3-piece IOL here and pushed the optic back so that it would have support from the posterior capsule instead of the anterior. The next case was on a patient with having cataract surgery, IOL implantation, as well as CTR with zonulopathy. And he showed how he does iris repair with fourth-row pupilloplasty. And he does this with the polypropylene suture. Here you can see his fourth-row pupilloplasty, but when you tighten the suture, still there could be some distortion to the pupil. So he showed a study by Dr. Ahmed where they use endothermal pupilloplasty using an intraocular diathermy that's available on the Centurion at very low power, and that can help recenter the pupil with small burns. But keep in mind that will cause some TIDs anywhere that you touch the iris, so make sure to use very low power. The last case that was interesting he showed was a case of a patient with corneal edema. You can see on the top left, dislocated lens, Sommering ring, and the procedure included placing iris hooks, doing a vitrectomy, placing a scleral fixated IOL, doing a pupilloplasty, and then a DMEC. So it's a bunch of small steps combined into one. He placed the sclerotomies 180 degrees apart, 3 millimeter from the limbus and 4 millimeter from the other sclerotomy site. He then cut the zonules with the actual vitrector to then remove the Sommering ring. And then he had 2 lens options that he presented us, but he showed the CZ70BD lens, which is a large lens that you place in with Cortex mattress sutures in the orientation shown in the photo here. And then he did a fourth-row pupilloplasty, not mainly to fix the iris distortion, but to compartmentalize the anterior segment so that when he does the DMEC, the anterior chamber or gas bubble can stay in to keep the DMEC opposed. So those were some interesting anterior segment recon cases he showed. The next talk by Dr. Kolazes was Beyond Phaco, Rediscovering Strength of Manual Small Incision Cataract Surgery. So she talked about how there's been many modifications of this procedure since 1999. Some advantages are that the endothelium is protected. There's no expensive equipment that's necessarily required, and essentially the whole time you're operating in a formed AC. So that is a good advantage, and it's particularly used in dense cataract patients in resource limited settings. So some of the technique points that she went over is to create a 7 millimeter scleral tunnel. She also mentioned making a frown incision, and that can help reduce your astigmatism. And you create this incision with a wider area closer to the cornea. While you're doing the rhexis, you do it through the side port. That's a smaller incision, so your AC is maintained, but you have to make sure you make a large rhexis because you want to accommodate the cataract to prolapse out. And at the end, to make sure you're using a 3-piece IOL. The next case was by Dr. Teichman talking about cataract surgery in the high myope and vitrectomized eye. So he did a little bit of talk around preoperative consideration. So the first is a refractive target and making sure you really counsel them to keep a nearer target for low myope. So if someone's around -2, -3, try to keep them in the low myope range because if they want to go for plano, though, they're going to realize quickly that they need their glasses for all near activity that they're usually used to not wearing glasses for. So counseling them and advocating for a near target is good. For very high myopes, where they're sort of blurry at all useful distances, and for cases where patients are going to have unilateral cataract surgery, you can either consider doing early cataract surgery for the other eye, or if there really isn't much of a cataract, you can consider offering them ICL for the other eye so that there isn't much anisometropia. For your measurements, looking at the A-scan and the IOL biometer, you should ensure that there's focus on the actual fovea. Some of these patients can have a possible staphyloma, so that's important to look for when you're considering the IOL calculations. And the formulas he recommended for long eyes are the Barrett Universal 2 or the Kane. Intraoperatively, he highly recommends maintaining the AC. These patients can have a huge AC, so you want to try to maintain pressure in that area so there isn't much fluctuation. Some of the things you can notice intraoperatively is lens iris diaphragm retropulsion syndrome, which is essentially reverse pupil block, where the iris gets tacked back down and your AC that you're working in can get even deeper. So during the case, you have to be mindful of this, look for it. If you see it's happening, then you can lift the iris periodically to get the AC in the right depth again. Or if you want to make things easier and it's happening frequently, you can just place a single iris hook for the full case. Other things to look for are that these patients can have loose zonules or lack of vitreous support if they've had previous vitrectomy. So some of the things you can do in these cases is bimanual lens rotation, and that kind of reduces the shearing force on the zonules. Make sure you're doing gentle chopping, and while you're stripping the cortex, try to go in a tangential manner instead of pulling to the center, so there's less force on the zonules. Things to consider using are CTS, CTRs, and Chang modified capsule retractors that you can see in the photo that helps reduce problems when you also have a CTR in there. For patients post-intravitreal injection or vitrectomy, you have to know that the capsule is breached until proven otherwise. So you treat it like generalized zonulopathy or like a posterior polar cataract in all cases. So things you do are you do hydrodelineation, you don't do as much hydrodissection. If you want, you could do viscodissection. Try not to rotate the lens and make sure you're doing gentle nuclear disassembly. The next talk was by Dr. Bakshi for cataract surgery in the uveitic eye, and she talks about pre-op, intra-op, and post-op considerations so that any general ophthalmologist can hopefully help manage these cases. So quickly going over, for pre-op cases, make sure you have a good basic workup so that you've controlled the uveitis prior to surgery. Things she recommends are CVC, light, creatinine, syphilis, ACE for sarcoid, HLA-B27 workup, viral, IgG, and IgMs, chest x-ray for TB as well as sarcoid, and AC tap is indicated. Some of the medications you can use is for topical steroids for a week prior, oral steroids for 2 to 7 days prior, and anti-infectives for a week prior. HSV, VZV, we use valacyclovir, CMV is valganciclovir, and Toxo is Septra. She says even if it does not look like the uveitis was caused by one of these infectious agents, if you see that they have signs of previous infection with these, or you see, for example, like an old Toxo scar, still treat them with anti-infective for 1 week because they can't reflare. For surgical planning, things to look for on exam is the IOP, AC depth. Have they had a previous PI? What does the angle look like? Some investigations you can do is gonioscopy, UBM to look at the anatomy, and sometimes you may need to consider that these patients need combined glaucoma cataract surgery. Intra-op, you may notice that they have small pupils. You may need to have zonulopathy management. So pre-op on exam, you look for things on the iris, pupil size, posterior synechii, PAS, and cyclitic membranes. So these patients may need posterior synechii dissection, and sometimes it's not just at the pupil margin. You may need to go deeper because they can have PS behind the iris as well. Things you may need to use and have on hand are iris hooks or the Malyugin. With the lens, you try to look for what is the density of the lens like? Is there any lens capsule fibrosis? What are the zonules like? Things you should do in advance are looking at the biometry and seeing whether it would benefit them to have femto, particularly for dense white cataracts to help you if you need it with the rhexis, as well as if you'll need CTR placement. For rhexis size, try to not do too small because you want to avoid phimosis and blocking your peripheral retina view post-op, and not too big to avoid eye wall subluxation, especially if they're going to need vitrectomy later. Consider doing monofocal or monofocal plus lenses. You can do torics if they have good zonules, and if they have good biometry, that shows that it would be okay. But we avoid EDOFs and multifocals, and we prefer hydrophobic eye walls. For the last part, looking at the posterior segment, check your view of the posterior segment. Is there any vitritis, any haze? What does the macula look like? Is there any pre-op fluid? And have they had a previous vitrectomy? Investigations you can do are B-scan, IVFA, FAF, and MAC OCT, and you should consider whether or not they need a combo phaco-vit in these cases. For intra-op steroids, she recommends a couple of things: 250 to 500 milligrams of IV methylpred intra-op, or anterior subtenon triamcinolone after the case is done, or intravitreal steroid at the end of your case. For post-op, there is a risk of worsening CME with the inflammatory milieu, so you can do ongoing MAC OCTs to monitor. They may need ongoing anterior subtenon, Kenalog, intravitreal steroids, prolonged NSAID course for 2 to 3 months, or even anti-VEGF injections. This is the table that I thought was helpful at the end, looking at how well their flare was controlled pre-op. You categorize them into low, moderate, or high risk of flare, and then you base your pre-op, intra-op, and post-op steroid and NSAID regimen based on this. So this table was quite helpful for people to use. The last case was by Dr. Devgan, what to do when the capsule breaks. Some interesting videos he showed. This photo is showing the snap sign. So here you can see the cannula is blocking the lens from coming up and during hydrodissection. So instead, the fluid caused a blowout of the posterior capsule, and you can see the snap sign in his video. You should also be aware for patients who've had vitrectomy and they suddenly come in with very early cataracts after vitrectomy, you have to consider there's a high chance that the capsule has been breached in these cases, so you need to be prepared for that in advance. If you do develop an indication to do an anterior vitrectomy in your case, make sure you're giving extra anesthesia beforehand. You can give more subtenons or IV anesthesia. Vitrectomy is a very patient procedure. You're going to have to do several rounds of it, several rounds of Kenalog. The whole time, try to maintain the AC to prevent further vitreous from coming forward. Have the OVD in your non-dominant hand to continuously fill the AC. Hydrate your wounds before IA to prevent fluctuations as well. For the lens, you want to make sure you enlarge your main incision for the 3-piece eye well. And when you're putting it in, you look for the leading haptic to have the number 7 sign when you're putting it in. And then the trailing haptic should be an L shape so that you make sure you put in the lens properly. For the bimanual vitrector, you can also use it as IA, how we talked about it with IA cut mode. And these patients post-op need very good close observation to monitor for CME, retinal tear detachments, and endophthalmitis. And that was section 4.
Okay, great. So I looked at session 5 where we talked about IOLs. I'll go through a little bit fast just for time considerations. So the first was by Dr. Osher, where he highlighted that you can have fibrin or hemorrhage seen on post-op day 1. Small amounts can respond to steroids, whereas large amounts can respond very well to TPA. Be on the lookout for TAS, or toxic anterior segment syndrome, very strong inflammatory reaction post-op day 1, and rule out endophthalmitis. Triamcinolone injection can cause a pseudo-endophthalmitis from the crystals themselves. Residual refractive error. Make sure the right lens was implanted. If an incorrect lens was implanted, have an honest conversation with the patient and offer prompt lens exchange. Retain lens fragments. If it's nuclear, they have to be removed. Cortical can respond to steroids. Posterior polar cataracts, you want to do a gentle hydrodelineation, not a hydrodissection. You can visco-dissect off the cortex. And even under viscode or Helon 5, you can dissect off posterior capsular fibrosis. Persistent inflammation and edema, especially with prior corneal scarring. Think about HSV reactivation. Negative dysphotopsias can be seen from the edema at the wound edge, and they can resolve as the edema resolves. Avoid having the phaco bevel to the side in the periphery, as you risk tearing the anterior capsule. Caution should be used when implanting a yellow tinted lens in people that rely on determination of color, such as artists. He had a nice quote here. I thought, patients don't care about how much you know until they know how much you care. Dr. Trin looked at pinhole optics and understanding how they can be used in aberrated corneas and presbyopic correction, such as a RK patient she showed here. And it's useful to show the patient all the different biometry, all different lens calculations, so they understand how difficult these cases can be. With pinhole optics, it enhances focus and extends the depth of field, such as the IC8 shown in number B here with a 1.36 millimeter central aperture. And it does preserve some distance acuity. It normalizes at least 1.5 diopters of corneal astigmatism. And you can do a pilocarpine trial to confirm that the patient is comfortable with the reduction in light transmission. When to use an IC8, such as presbyopic correction in the non-dominant eye, if there's a high risk of refractive miss, non-qualifiers for trifocals, and if there's irregular astigmatism. You should be cautious using an IC8 if there's corneal scarring or macular pathology, reduced contrast sensitivity such as glaucoma, the presence of vitreous opacities. risk of poor centration or stability. And with large pupils, as you can get dysphotopsias. Our own Dr. Sangera looked at the light adjustable lens, noting that it can be difficult still with technological advances and formula advances to get manifest refractions post-op less than 1.5 diopters, less than 0.5 diopters. And to optimize outcomes post-operatively, they used to be more invasive, such as LRIs, lens exchange, or laser vision correction. But now you have a non-invasive option in the light adjustable lens, or LAL. With the LAL, after it's implanted, it's a photoreactive silicone lens, monofocal with a negative spherical aberration. You use light to activate macromers that are within the lens. That causes a polymerization, and you can change the shape of the lens with a high degree of accuracy. When he uses it, he tends to either have both lenses targeted for plano or have the non-dominant eye slightly myopic with more spherical aberration to enhance range and binocularity. You can use the LAL if patients are able to be well dilated and have a relatively low, less than 2.25 diopters of regular corneal sill and have a normal cornea and retina. However, they do have to position at the machine for the adjustments and lock-in after op. And he shows some very impressive results with the dominant eye achieving very good distance visual acuity, actually on average better than 20/20. And in the non-dominant eye, still a good distance of visual acuity and very good near vision of J2. So he was able to achieve 20/20 J2 vision across a continuous range with minimal glare. Dr. Weichert looked at misaligned toric IOLs. These can be, the causes of residual astigmatism can be errors in biometry, poor IOL choice, or misalignment of the IOL. And toric rotation is actually relatively common, with more than 10% of lenses being rotated by 2.2 to 6.8% from their intended target. For biometry errors, you want to recheck measurements and quality metrics. Is the astigmatism symmetric and regular, and was it toric warranted? Repeat the biometry and the topography, and also repeat the manifest refraction and assess the ocular surface, and confirm a good IOL choice. To determine the actual IOL alignment, you want to dilate the patient on post-op day 1 if the vision is relatively poor, less than 20/40. You can measure it at the slit lamp or with photo apps and try to identify sources of error, such as marking, and maybe you might benefit from an automated system. There are online calculators, such as the BH Astigmatism Fix, that you can put the manifest refraction in and determine if IOL rotation would actually help the patient. For management options, those include glasses or contact lenses, refractive surgery, IOL rotation, and IOL exchange. And you want to take steps to maximize the IOL stability intra-op. Make sure the haptics are fully unfolded, remove OVD completely. Here he is going in behind the lens. Maintain AC stability, leave the eye soft, and keep the patient at rest for about an hour, as that's when you're most likely to get toric rotation. And he noted that studies have shown no clear benefit that a CTR improves rotational stability. Dr. Devgan looked at the effect of pupil size in EDOF and multifocal IOLs. With the Vivity, there's a 2.2 central focusing element that's more curved. In a large pupil, because about a quarter of the light goes through the central element, you can aim plano to get plano. However, if the pupil is small and more light is going through the central zone, you might actually want to aim a bit hyperopic to achieve a plano result. With the Symphony, the diffractive rings are throughout the lens. So in both the larger and smaller pupil, you can aim plano to get plano. With the IC8, with a small pupil, that might block a lot of the light transmission. And in both cases, with a large pupil and small pupil, you can take advantage of the pinhole effect and aim for a little bit minus to get more range. With the Eyhance, there's a 1 millimeter, very small central focusing element. With a larger pupil, they might not get as much benefit from that, as only a small percentage of the light goes through. But in a smaller pupil, they might get some benefit and increased depth of focus. Dr. Ayers looked at IOL exchange, taking us through viscodissection, getting the lens out, and placing a new IOL in the eye. With viscodissection, he likes to use 3 paracenteses for better access, and you can use additional tools such as microforceps, not to grab the capsule, but to tent it up and aid in viscodissection. For removing the IOL, you want to do a lifting and twisting technique to get it out of the bag. There's many ways to remove the IOL. He prefers to cut, but there's fold, twists, or pull methods. And for placing a new IOL in the bag, you just want to make sure you have adequate capsular support. And you can place it in the bag, in the sulcus, with or without optic capture or fixated IOLs. You want to be comfortable with vitrectomy should they have an open posterior capsule, such as a post-diag. And what if there's no capsule? With scleral fixation, there's new tools you can use, such as this device that's a 27 gauge needle with forceps built inside to help dock the haptic within the needle. And if you're going to be placing something in the bag with the IOL, you want to use a CTI for stability. And finally, our own Dr. UofT showed many impressive videos about the Yamani technique. He notes it's simple, reproducible, cheap, inexpensive instruments with good results and few complications. Some pearls included IOL selection. If you're just starting off, something with a PVDF haptics might be better to use as they're a bit more pliable and more forgiving. The importance of proper marking to ensure good IOL centration and lack of tilt, using an AC maintainer, good paracentesis and main wound position and architecture, and also some tips on grabbing the haptics. Once you get good at these techniques, you can even do it when you have poor visualization, such as the case of pseudophakic bullous keratopathy. And you can actually use the lens as a scaffold to attach other things, such as an artificial iris. And here he is implanting one actually open sky, and we'll do a full thickness transplant of the cornea after the Yamani is done.
All right, and now we're just gonna go over the video Sheikha made for section 6.
Good morning, everyone. My name is Sheikha, one of the PGY5s, and I'll be discussing session 6 of the Walter Wright Symposium. Session 6 started with a talk entitled Presbyopia Correction, Optimizing Monovision by Dr. Mitchell Weichart. He described monovision as being a great marriage of visual quality and function with the goal of increasing range of vision. Advantages of monovision were that monofocal IOLs maintain optimum visual quality with no additional cost and high patient satisfaction, 73 to 90% rated as acceptable to very satisfied. The disadvantage would be that there's no complete spectacle independence, especially driving at night or extended reading due to fatigue. There can be decompensation of pre-existing phoreas with time and potential loss of stereo acuity. He discussed monovision versus multifocal IOL, with the main difference being that near visual acuity wins with multifocal and stereo vision, whereas contrast sensitivity is better with monovision. Dr. Weichart suggested before trying monovision to operate on the non-dominant eye first, to rule out any previous straps, to consider pre-op contact lens trial, and to leverage any corneal positive spherical aberration for an aberration-free IOL. The current present of monovision, previously described as the future of monovision, was the LAL, the light adjustable lens. This allows us to nail the distance eye, which is key to success, and allows determining the optimal level of anisometropia. The next talk was by Dr. Amrit Rai, entitled No Frills, Just Focus, an Overview of Monofocal Lenses. He started by describing the monofocal IOL as being the vegetable of ophthalmology. It's not very exciting, but it's good for us. He went on to discuss spherical aberrations and how they're peripheral light rays which focus anterior to central light rays, resulting in no single point of focus. Patients with positive spherical aberration positive spherical lenses have reduced contrast sensitivity with increase in depth of focus and depth of field, whereas zero spherical aberration or aspheric lenses have high contrast with reduced depth of field. And negative spherical aberration are also spheric lenses with reduced contrast and increase in the depth of field. The natural human cornea has a positive spherical aberration of plus 0.27 and a Q value of minus 0.27. A young eye maintains a positive spherical aberration at the level of the cornea and a minus spherical aberration at the level of the lens, resulting in neutral spherical aberration in total. As a person ages, the lens shifts more towards a positive spherical aberration, which can be corrected for with a negative spherical aberration lens. And this can get a little bit tricky post-refractive surgery, where For example, post-myopic LASIK, the cornea is more oblate, resulting in a more positive spherical aberration, in which case we should be opting for a negative spherical aberration lens. Patients who are post-hyperopic LASIK have less positive spherical aberration as the cornea is hyperprolate, and therefore we should be opting for a more neutral spherical aberration lens. He described the effect of spherical aberration on IOL as well, and IOL location. So for example, IOLs that are neutral in their spherical aberration contain constant power from edge to edge of the optic. IOLs with positive spherical aberration have effective power which increases towards the periphery, thus resulting in the positive spherical aberration. And those with negative powers essentially have the opposite, the effective power decreases towards the periphery. And this comes into play with IOL decentration or large angle alpha. Dr. Wright therefore suggested that if the patient has conditions like pseudoexfoliation syndrome or trauma that predispose them to having IOL decentration, the best is to choose a neutral IOL. Dr. Rai concluded his talk with this great IOL decision tree. In this case, he breaks it down into an abnormal and normal cornea. So, for example, in a patient who underwent hyperopic LASIK, it's best to choose an IOL with positive or zero spherical aberration. Those with myopic LASIK, it's best to choose an IOL with negative spherical aberration. Patients post-RK or irregular corneas, zero aberrations, or even an IC8. Those with refractive unpredictability, the LAL works best. Patients with normal corneas but have a risk of IOL decentration, perhaps a zero spherical aberration would work best. Those who request or require intermediate vision, a monofocal plus or IOL with zero spherical aberration would work. And those who require the sharpest distance vision with normal corneas would do great with negative spherical aberration IOLs. Dr. Michelle Khan followed Dr. Rai with a talk entitled The Magic of Enhanced Depth of Focus. She started her talk by describing that the current aging population demands spectacle independence, especially for intermediate vision. EDOF has been the most popular IOL choice in a lot of refractive practices, accounting for 30% of their choices, and EDOF function with providing elongated focal points. She took a moment to describe the difference between depth of focus and depth of field. Depth of focus being the distance in front of and beyond the subject that appear within focus, whereas depth of field is the distance in front of and beyond the subject that appear clear. And we are discussing depth of focus. She went on to describe multiple different kinds of EDOF lenses, starting with the Vivity lens, which uses wavefront technology, and it's found to be superior for near and intermediate vision compared to a monofocal lens. She discussed a study that compared Vivity versus a Symphony, where the Symphony was found to have more visual disturbances like glare and yellow profile, and the Vivity had a more favorable dysphotopsia profile compared to a trifocal, and better spectacle independence compared to a monofocal. When it came to the IC8 Apthera, it has a bit of a pinhole effect, which blocks defocus from paracentral light rays. Dr. Khan also discussed Technis Pure C, which is a refractive EDOF lens that showed consistent acuity across a range of distances, superior to the iHands and to the monofocal. She also discussed the iHands, which lies somewhere between a monofocal and an EDOF. Vivity gave better near vision compared to iHands and better intermediate vision. She, before concluding her talk, took a moment to describe the importance of pupil size being a factor in visual outcome in presbyopic IOLs. She discussed that pupils that were larger than 4 millimeter in size had worse near vision for IOLs such as the Symphony, but it wasn't the same uniform effect in all presbyopic IOLs. Special considerations should be done for patients who have glaucoma, for example, as a sensitivity to decrease in contrast with glaucoma, so it's best to avoid trifocals. She concluded by saying that understanding patient expectations is key. Dr. John Lloyd followed with a talk called Multifocal Mayhem, an overview of the proliferation of presbyopia correcting intraocular lenses. He took us through a tour of his own personal experience with multiple multifocal lenses, starting with the Restore, where patients although were 20/20 in visual acuity, were found to have waxy vision. Patients with the Technis Symphony had complaints of glares and halos. Patients who were using fine vision and panoptics after that allowing additional diffracting grading. The fine vision had 90% satisfaction in Scandinavian countries, and the panoptic toric was found to be best for those with higher cylinder. Dr. Lloyd's own patient had pretty good satisfaction with both, but he did find that there was a shift towards hyperopia with fine vision and switched to panoptics. He found that the worse the refractive error and the more presbyopic, the better the candidacy. Dr. Lloyd also took a moment to discuss angle kappa, which was basically positive when the fovea is located temporally in a typical case. And it's been thought that if you can control the centration of the lens on the visual axis, not on the pupil center, and it's a bit debatable whether centration of the lens can be controlled or not. Dr. Lloyd described his personal work on angle kappa, where he conducted a study amongst thousands of patients, 72% of which had angle kappa greater than 0.5 millimeters, and there was no refractive difference between them. There was a minimal trend towards marginally worse results with higher angle kappa, though the trend was almost flatline. Satisfaction survey showed absolutely no difference, and those who were not satisfied came from a wide range of angle kappas. He therefore does not think that this is the holy grail of IOL selection. Dr. Tanya Trin followed Dr. Lloyd with a talk labeled Unconscious Gender Bias, Being an Ally. She discussed the importance of imposter syndrome and the fact that it was perpetrated by both men and women upon women, that it can be incredibly harmful when cannot be seen and can silently erode confidence in women. Women are uniquely predisposed due to additional societal expectations. Women and men interpret success and failure very differently. So why should we care? Because this can result in stress, anxiety, burnout that can result in cost not only to the organization as a whole and to the individual as well. So being a champion of change requires engagement from both sides. Men especially are in gatekeeping roles and thus play a very important role in supporting women through this process. The next talk was called Future of Cataract Surgery in Ontario by Dr. Sharif Al-Dafrawi. He started by describing the principles of the Canadian Health Act, which were public administration, comprehensiveness, universality, accessibility, and portability. He talked about the cost of surgery, which ranges from the facility fee to the surgeon fee. He gave Kensington Eye Institute as an example of a non-for-profit charity which started receiving government funding in 2006. And then he posed the question, how does a for-profit center survive if they can't get a facility fee and they cannot bill the patient for medically necessary services? They therefore bill for non-medically necessary services like premium lenses and tests. The same is for patients who have colonoscopy procedures or knee replacements. Things shifted in 2020 when the COVID pandemic wreaked havoc on operating rooms. And in order to catch up on urgent surgery, the government allowed hospitals to transfer some of their cataracts to private centers for the first time. Bill 60 allowed for for-profit centers to perform publicly funded surgery. This was a slippery slope for privatization, and there's arose concerns for a two-tier system. Studies show privatization does not affect wait times, actually, since the same surgeons and the same workforce support both surgeries, both locations. There's actually a perverse incentive that maybe maintaining wait times publicly encourages these private centers. Evidence show that private healthcare is more expensive, it's less efficient, and does not reduce wait times. Studies also showed that even with government funding, there remains a disparity skewed towards the wealthy for receiving surgery in private centers. The worry remains that physician-owned centers will eventually be sold to private equities in the future. He concluded by describing what can be done for this. Private for-profit centers should not get government-funded cases. We should be able to expand hospital facility and provide non-for-profit centers. And we should be working hand in hand with regional provincial planning and expansion of the workforce. The final talk was by Dr. Kathleen McCabe, which was the Jeff Hurwitz named lecture, Global Ophthalmology and Giving Back and Leveling Up. Dr. McCabe described how 1.1 billion people globally are visually impaired, 90% of which have reversible changes. The greatest things were uncorrected refractive error and cataract. This is predicted to be almost 2 billion people by the year 2050. And we all know how vision affects the overall health and mental health as well. She described the need for more facilities, for more healthcare workers. She spoke of her time in St. Vincent, where she works in the local hospital and provides care for local patients. She said there's almost always more people showing up than they were expecting. She runs parallel optometry clinics and distribution centers. There are operating rooms and seeing post-ops just outside of the operating room. She also describes how she uses this as an opportunity to provide mentorship and teaching for local surgeons to allow for transfers of skills. She also spoke of her time in Kenya, where they impressively run 3 surgeries going on at the same time. She showcased a myriad of difficult and complex cases ranging from ocular trauma, burns, dense cataracts, serving the elderly, from the elderly to the very young. There were no phacos, and she works heavily using the M6 technique. She showcased the ingenuity that global ophthalmology demands, for example, using MyLoops even for black cataracts, using handheld battery-powered retractors when needed. She concluded her talk by saying that she shares her passion with her family and exchange students to create long-lasting impact. Thank you very much.
Thank you all. That was a great summary of what was a great and very informative Walter Wright. Thank you all for summarizing the 2 days, the packed 2 days of talks into 1 hour rounds. We don't have much time for discussion, unfortunately, but we'll reach out to you if we have any questions. Have a great weekend, everybody. Please don't forget to fill out your evaluations and claim Royal College credits, and we'll see you all in the new year. I think this is the last grand rounds of 2024. Bye, everyone.